Welcome to the latest in our Movement is Life online symposia series exploring health disparities and health equity. Thank you for joining us today for our exploration of health have and have-nots now and beyond the pandemic with Professor Sandro Galea. I'm Dr. Mary O'Connor, Chair of Movement is Life and an orthopedic surgeon. I'm the Chief Medical Officer with Voya Health, a healthcare startup with a mission to empower humanity to lead its healthiest life. Prior to co-founding Voya Health, my career was in academic medicine as a professor of orthopedic surgery at Mayo Clinic and at Yale School of Medicine. Dr. Galea is a physician, an epidemiologist, and published author, including the highly praised book, Well, published in 2019, which explores remedies to our healthcare challenges. Dr. Galea is Dean and the Robert A. Knox Professor at Boston University School of Public Health. He previously held academic leadership positions at Columbia University, the University of Michigan, and the New York Academy of Medicine. He has published extensively in peer-reviewed literature and is a regular contributor to a range of public media about the social causes of health, mental health, and also consequences of trauma. Dr. Galea is chair of the board of the Association of Schools and Programs of Public Health and a past president of the Society for Epidemiologic Research and of the Interdisciplinary Association for Population Health Science. He is also an elected member of the National Academy of Medicine. I'm sure you appreciate, as I do, that he is well qualified to speak on this topic. If you visit his website at sandrogalea.org, you will find a trove of insightful articles and essays, including his concept for The Healthiest Goldfish, an ongoing blog and commentary. In today's virtual conversation, Dr. Galea is going to discuss how our health is fundamentally socially patterned, and as such, the health of our communities reflects the world around us. Our format today will be a presentation followed by questions. You can submit your questions using the Q&A button and the comments via the chat at any time during the presentation, and then we will discuss as many as we can with the time we have after the presentation. Welcome, Dr. Sandro Galea.
Thank you, Dr. O'Connor, and thank you for inviting me to be here, and thank you to everybody who is here today. Thank you to the technical staff who made this possible. It really is a privilege to join you today, and I want to talk about COVID because, well, COVID is all we've talked about for the past year. But what I'm hoping to do in my talk in the next 30 to 40 minutes or so is to give you my perspective on how we should talk about COVID and what I think is the key story of COVID. And what you'll see is what I think is the key story of COVID is probably different than the one that is the popular narrative, which is has been around a very particular aspect of COVID. But I think the notion of how COVID has affected us, how it has affected health haves and health have-nots, is central to our understanding of this pandemic and how we can think about future pandemics. So I'll start with this. So the first point is COVID is a triumph of science. It is a triumph of biomedical science, and we should not forget that. There is no question to my mind that COVID has shown us that our investment in biomedical science is really paying off. Now, what do I mean by that? Well, I can start by talking about mortality from COVID. This is a graph from a study that came out of a group in New York University, which shows the mortality from COVID and starting in March of 2020, which is when we first recognized COVID. But the point I want to look at is the blue lines. And the point about the blue lines is as follows, is that within a couple of months of us recognizing COVID as a disease, remember, we did not know COVID before, it was a brand new disease. Mortality from COVID dropped almost fourfold. That is actually quite amazing. It is quite remarkable to have mortality from a disease drop so much when it was a disease that was previously unknown. Why did we do that? Well, a lot of things. We improved clinical experience. They're using pharmacological treatments like remdesivir, steroids, better non-pharmacological treatments, things like proning, and potentially lower viral load as we started wearing masks and recognizing that also matters. So a disease comes on, one we had never known before, and within months, we dramatically drop mortality from it. And then, of course, the crowning glory of the biomedical approach in the context of COVID is vaccines, is our vaccination, is arriving at safe, effective vaccines within 10 months of the disease first being identified. Of course, the actual vaccines we had within months, and then the testing, the phase 2-3 trials took most of that time. Now that is extraordinary. It really is extraordinary when previously vaccines typically take 10 years or more. The fastest ever vaccine we had developed was the mumps vaccine. It took us 4 years. And a lot of the vaccines that emerged first were based on totally new technology, on mRNA technology, which is from a paper about 10 years ago about mRNA vaccine technologies. And I like this quote in this paper: mRNA presents a promising vector that may well become the basis of a game-changing vaccine technology platform, which is exactly what it has become. So an investment in biomedicine, an investment in clinical care, an investment in vaccine technology resulted for us at this moment of COVID, an opportunity for biomedicine to really help find a way through COVID. So that's all to the good. But is there a problem? Is there a problem? And why am I speaking like this? Like there is something that is that influences how we think about COVID. Well, I do think there's a problem. There's been many problems despite the drive for biomedicine. And to talk about those problems, we first need to understand health. Now, I know that by virtue of the fact that you're spending your time on this webinar, you care about health, that health is part of what you do. So you may say, well, why do I need to understand health? But I think it's helpful sometimes to take a step back and say, what is health? How is health generated? And how does that influence how I think about health and what we should do about it? And I find it helpful to tell the story of health by talking about this story. Now, for those of you who know the blues, this is blind Willie Johnson. He's a blues man who we remember him today. We have about 36 of his songs still recorded. And Willie Johnson was born in Texas at the turn of the 20th century. And he was born sighted, the story goes, and he lost his vision in a domestic violence incident when he was about 7. So he grew up poor and blind and black in Texas in the early 1900s. He learned to play guitar, made a living busking, and which is sort of how we remember him as he became one of the influential forefathers of the blues. As you can imagine, not a very good living. He got married. He was living in a house, and the house that him and his wife were living in burned down. But they didn't have any money, so they actually went back and they kept living in the same house that burned down after sort of the fire had died down. When he was in his early 40s, the blind Willie Johnson developed malaria. And this is Texas in the 1940s, so malaria was not uncommon. Many of you will know that the Centers for Disease Control was initially started to help control malaria in the southern states. And his wife took him to hospital, and he was turned away from hospital. And it's not clear if he was turned away because he was poor, because he was black, because he was blind. But then he died. Now, I tell that story to ask you the question, what killed blind Willie Johnson? Well, what killed blind Willie Johnson was malaria. Malaria is what he went to hospital for. Had he received treatment for his malaria, he would have lived. Malaria is what killed him. But the reason I tell the story is because anybody listening recognizes that it wasn't just malaria that killed blind Willie Johnson. It was a whole range of other factors. It was domestic violence. It was racism. It was poverty. It was homelessness. It was poor access to care. All these forces contributed to killing blind Willie Johnson. And that, of course, makes all the difference. That yes, malaria is what killed him, but all the other forces contributed. So a triumph of biomedicine is the treatment of malaria. But even if we treat malaria, and we treated malaria in blind Willie Johnson, I think everybody recognizes that he would have died of something else the next day or the day after, because we weren't dealing with all the other factors in his life. Now, this is entirely consistent with how we think about, with how we structurally think about health. This is from an institute that looks at these things and looking at what's the percent of drivers of health. Well, healthcare, medicine is about 10 to 20% of our health. But health behaviors, our smoking, our diet, our alcohol use, where we live, where we work, where we play, our education, our job, our family supports, our income, all of that matters. All of that fundamentally matters much more for our health than does medicine and clinical care. Now, at this point, you can do one of two things. You can either agree with me, which is good, and we can proceed, or else we can disagree on that. And that's fine, and we can have that argument. But assuming for a second that we agree on this, then we can say, is this such a radical concept? I don't think so. I don't think it's a radical concept. I don't think it's a partisan concept. I don't think Republicans or Democrats disagree on this. I think most rational people, when they hear blind Willie Johnson's story, they say, okay, I get it. I get how all these other factors matter. So I can say, well, if we get it, if we know how all these other factors matter, do we act on it? Is that how we spend our money, for example? Well, let's look at how we spend our money. So I can take this same graph, and that same figure is the same figure now on the left, which is now rendered black and white. And you can see the percent at which there is things that cause health. On medicines, about 20%. On the right, you can see what we spend our money on. Well, what we spend our money on is almost all of it on our medicine and clinical care. 90% of it is we spend on medicine and clinical care. Everything else, which is the vast majority of what constitutes our health, is not what we spend our money on. Now, on top of this, we spend a lot of money on health because this is us, this 28 data going up to 2018. The top line, which is the sort of the greenish teal line, is US spending. You see going up more and more and more, higher than all other high-income countries. In fact, we spend about 40% more than other high-income countries as the US on health. But we spend it, as you saw on the previous slide, disproportionately on treating malaria. And obviously I'm using malaria as a metaphor, but we spend it disproportionately on treatment and clinical care. And on all the other forces, in fact, we are spending less and less. There's another graph that shows this. You see Social Security spending with a dark blue line, sort of a stable bar at the bottom. But look at healthcare programs. You see how that's increasing? That's the light blue. And look at all other spending, slowly contracting, slowly getting less and less. Now, different states are, of course, different in this. And I live in Massachusetts, which is a state that prides itself on being progressive and forward-thinking about matters like this. And sometimes I like to remind the audiences, when I'm speaking in Massachusetts, about how are we doing in Massachusetts. So this is percentage spending over a 15-year period in Massachusetts. What you see is healthcare increased by about 100%. Spending on transportation and housing, primary, secondary education, mental health, higher education, early childhood education, public health, environment and recreation stayed the same or went down. So to apply this to the blind Willie Johnson story, we are spending a lot on the malaria treatment. We're spending more and more on the malaria treatment and less on everything else. And I started this talk by saying, in the context of COVID, it's been a triumph of biomedicine, which is, of course, extending the metaphor, the treatment of malaria. It is the other pieces where we have fallen short. And as I've made the case here, hopefully you see, the other pieces are the majority of what matters for us doing well at any time, particularly in a time of COVID. And by the way, before COVID, we've been paying a price for this. What's the price we've been paying? Well, we can look, for example, at life expectancy. This is life expectancy in the US. We are the reddish brown. The other colorful lines are the other high-income countries. I like the slide because it's called American Exceptionalism with a little bit of irony, showing that our life expectancy over the past 40 years has, broadly speaking, been separating from other countries. We're now about 5 years less life expectancy than the other high-income countries. That means that we are choosing to live 5 years less than other countries. Now, you may be sitting there thinking, well, I didn't choose that. I'm not choosing. We did. You did. I did. Dr. O'Connor did. We chose to live 5 years less because we are part of the country that allows us to invest the way we do in health, that creates conditions where we live 5 years less than anybody else. So what is it that we should have been spending on? Well, we should be spending on all the other forces that created life for blind Willie Johnson. We should have been spending money on education, on nutrition, on parks and opportunities for recreation, on lifting people from poverty, on making sure everybody's stably housed, on reducing social isolation so that people do not have mental health problems, on creating a clean environment. These are the forces in the world around us that ultimately shape how we live and our health. And perhaps if there were one slide that would capture this argument so far in the presentation, it's this slide. This is life expectancy on the y-axis, spending on the x-axis. And what you see is all these other countries, they all go up together. It's like a straight line. You spend more, you get more life out of it. The US, though, we spend more and we fall off the chart. We actually get less out of it. And let me ask you this. Here's my challenge to you. Name one other sector where we spend more and get less. If I were to tell you that your cell phones cost more than they did in all other high-income countries, but they were slower and held less data, would you buy your cell phone? Probably not. You probably go to Canada to buy your phone. That's what you do. But for health, we somehow accept that. And I actually don't think I would challenge you to think of any other sector where we accept this, but we accept this on health. And we accept this on health, I would argue, because we misunderstand it and because we are so taken by the allure of treating malaria, of biomedical treatment, by the dramatic role that it plays, even though it is such a small proportion of what makes us better, that we continue doing this and we continue investing more and getting less. Now, remember, all of this is still pre-COVID. Now, that's our fundamental situation. Now, how about this health have-nots and health haves idea? Well, part of the problem is not only are we misinvesting and underinvesting in particular areas, what we are investing is unevenly distributed. So let's talk about that. Let's talk about our underlying social divides. And I'm going to argue that there are two principal axes around which we have underlying divides: socioeconomic axes and racial axes. And the two are intertwined. They're like a braid. They go together, but they also have distinct patterns. Let's start with socioeconomic divides. And let's start with the most obvious divide, which is around income. It's easy to look at income. So here's income over the past 40 years. Income in this country has really only risen for the richest 20%, the richest quintile. You see, that's the top line. Richest quintile, really income has risen. The poorest 80%, income has not risen at all. It's actually quite amazing when you think about it, right? That the richest 20% is the only group that has realized, effected a change in income. The poorest 80% has not had a change in income. And of course, this is highly intermixed with race. There's a lot of lines here, but what it's doing here is looking at race and education. And what you see is the top line, income, increasing more for whites with more, with a 4-year college degree. The lowest increase in terms of income is for Black Americans with less than a high school diploma, and that's the dark blue line at the bottom. So income, richest 20%, stratifies then by race and education. Now, income is one thing. Wealth is another thing altogether, because of course, wealth is transmitted intergenerationally and reflects underlying assets and investment in assets. And the gap in wealth dwarfs the gap in income. This is white families and Black families. On the left, what you see is income. So you see income over the past 40 years. So first you see white families having more income than Black families. Notice how overall, right? Notice how the income hasn't really increased for either white families or Black families. That reflects the fact that income increase has only been for the richest 20%, which means in aggregate, we're actually not increasing that much. But look at wealth on the right. Look how wealth, while there is about a 2-fold difference between white and Black families' income, there's about a 10-fold difference between white families and Black families' wealth. And that difference extends over multiple directions, multiple axes. This is household wealth by race and education. White is the blue on the left, Black is red on the right. Look how even in post-college educated households, you have about a 4-fold difference in wealth between white families and Black families. By income level, look at wealth by income level. Again, you have about a 3-fold difference at the highest quintiles of income between white families and Black families. And what's amazing about this wealth gap is that it's actually been increasing. So what you see here is the racial wealth gap, again, over roughly a 40-year period. On the left is everybody. The blue bar is 1983, the red bar is 2016. So overall, our wealth hasn't really been increasing, which reflects, by the way, stagnating incomes overall. But look at white wealth, which is the next bar, that's been going up, while Black wealth and Latino wealth has stayed the same or roughly has gone down. And this maldistribution of underlying resources that creates haves and have-nots traces back to historical disenfranchisement of groups. It traces back, in the context of Black Americans, to the history of slavery. This is the map of Black Americans who were held, who were enslaved. And you look at the southern United States, and you see sort of the pictures where there were more people who were held enslaved. And of course, there has been a long tail and a long legacy of that. That led directly to a whole set of other laws, including, for example, a history of redlining. This is the Home Ownership Loan Corporation that was charged by the federal government in creating conditions for more home ownership. Of course, what that resulted in is in them creating maps. This is a map of Detroit, where they would mark areas which they thought were good bets for lenders. Redlining, the phrase redlining, comes from areas that were marked in red, which the Homeowners Loan Corporation did not recommend to banks as being good investment for loans. The red areas, of course, were areas where more African Americans lived. And that's Detroit. And that, of course, maps onto segregation today. The same line you saw there becomes 8 Mile Road today. These are green dots, blue, and the blue dots, Black Americans, white Americans. Immensely segregated city, tracing directly to practices in the 1930s and 1940s, which trace directly to the Jim Crow post-Reconstruction era and ways in which we have continued to segregate and separate racial groups and disenfranchise people of color in the country. Now, these unevenly distributed assets become, perhaps inevitably, health divides. So there are divides which become health divides. And these health divides manifest in many ways. Now, notice, all of this is still pre-COVID. I will get to COVID in a second, but I do want to remind you that everything I'm saying, I could have told you were I invited to speak here in 2019. Like, this is all the same narrative, 2019, as we have here in 2021. This is even before COVID hit. So how did the health divides manifest? Well, we have, let's take something very simple, life expectancy. Life expectancy is roughly going up, although there's been a downturn recently, which we'll get to. But Black life expectancy is historically about 3 to 5 years lower than it is white life expectancy. Again, reflecting this pattern of underlying asset maldistribution. If I were to go back to that map of slavery that I showed you earlier, this is the same map of slavery, but before I showed it to you, an old-timey like a sort of map, this is rendered as a geographic information system. It's the exact same map. You see the darker color is where there were more Black Americans who were enslaved. The reason I'm showing this map again is because this now maps onto this, which you see is actually a very similar pattern of where there are darker colors, and that's the stroke belt in the country. Just as a very simple illustration of how the historical patterns of people being enslaved actually becomes patterns of greater disease today. And I can show you this in many ways. This is African American versus white mortality rate. You see Black is blue, white is red, higher mortality rate for young, middle-aged, older age African Americans. I can show you this in terms of risk factors, high blood pressure, diabetes. Again, higher risk factors for Black versus white Americans, younger age, middle age, older age. And I can also show you how the systematic pattern of disenfranchisement I showed you earlier maps onto poor health today. So for example, I'll go back to the redlining map. So the map on the left is the same homeownership loan corporation map of redlining, the same red patterns, only before, again, I showed you an old-timey map. Now it's rendered in GIS. The map in the middle is how neighborhoods were affected by foreclosures in the 2008 recession. And what you see is where you have more red, you have the darker colors. The map on the right is poor health. So you see redlining in the 30s, foreclosure during recession 2008, poor health in the past decade. So one can well connect these patterns of marginalizing group to having fewer resources that become poor health today. And coming back to socioeconomic position, as I said, I'm weaving in socioeconomic position and race, it's like there's a braid throughout. This looks at the richest 20% and the poorest 80%. The richest 20% is consistently has better health. This is CHF, angina, heart attack, and stroke. The richest 20% is the green, poorest 80% is the yellow. What you see is less CHF, less angina, less heart attack, less stroke in the richest 20% versus the poorest 80%. The very fact that I can sit here and talk to you about the poorest 80% is remarkable, right? The phrase poorest 80% probably shouldn't even exist in our lexicon. We really shouldn't be having the term poorest 80%. That is really the vast majority of people. But the vast majority of people are left behind on health compared to the richest 20% based on the growing gaps in haves, have-nots, translating into health haves and health have-nots. And just as I showed you the widening of the resource gaps, I can also show you the widening of the health gaps. This is angina and heart attack. The, again, poorest 80% is the yellow, richest 20% is the green. You see how angina prevalence is diverging. There is less angina in the highest resource group, more in the poorest 80%, same as heart attack, less heart attack in the richest 20%, more heart attack or the same heart attack in the poorest 80%. And I can show you this again and again, CHF, angina, heart attack, stroke. Look at the richest 20%, poorest 80%. On the left, you have 20 years ago, 1990, 2000. On the right, you have 5 years ago. And look at what the gap in CHF was 20 years ago. Look what it is now. It's wider. There was no gap in angina 20 years ago. Look at how wide it is now, et cetera, et cetera. And this, of course, maps onto, as underlying resources are more and more poorly distributed, also we find that health is worse distributed with more health haves and health have-nots. And just one last slide on this before I switch to the COVID moment is, because I've talked about socioeconomic position and I've talked about race, I just want to point out, again, they come together. They're constantly coming together. They're separate, but they also come together. And I like this slide that describes how they come together. This looks at 6 diseases again. They all behave the same way. Just focus in the middle where there's asthma. If you just look at asthma. What you have here in this graph, in this scatter plot, is on the x-axis, you have income. And these are all census tracts in the United States. On the y-axis, you have percent of people with asthma. So what you see here in the middle is there's a cloud of dots, right? Well, there's a line that goes through this cloud of dots. You can imagine a best fit line that says very simply, the more the neighborhood income, the less the asthma, right? So more resources, less the morbidity. That's fine. But then what it also does is it colors the dots by the percent Black population. The more purple the dots are, the higher the percent Black population in the census tract. And what you see is that the overall pattern is one where more income, less disease, but the Black population is concentrated at the lower income, more disease part of the curve. And that gives you a sense of how socioeconomic position and income come together to create the kind of picture that we see today. So all of that was before COVID. I could have given you those past 20 minutes in 2019, 2015, 2010. But then COVID hits. So COVID hits and finds that world that I just described. So what about the COVID moment? Well, we know the COVID moment has been an extraordinary moment. It has been we've had more than 500,000 lives lost. Many millions, pretty countless millions who've been infected in the United States alone. We could even talk globally. And of course, the COVID moment has been accompanied by enormous social efforts to mitigate COVID. This is a picture of empty Times Square as we isolated and moved inside. Well, all of that has come at a real price. All of that has come at a real price in terms of assets. This is job loss. This is 10% of Americans lost their job really between February and April of 2020. Jobs went down to the lowest level they've ever had in this country since 1975. But the effects of the COVID recession were not evenly felt. In fact, they're actually quite unevenly distributed. This looks, for example, at job losses again. Then there are 3 lines. You have a red line, which is high wage workers, the teal line, which is middle wage workers, and the dark blue line, which is low wage workers. What you see is that while everybody's jobs went down dramatically in the first few months, then recovery happened quickly. High wage workers recovered very quickly. By the end of 2020, there was no drop in employment for high wage workers. The drop was among low wage workers, which remained 20% below what it was by the end of 2020. Now, of course, based on what I just showed you, you realize that low wages and low socioeconomic position are associated with poor health, again, before COVID hit. So when COVID hit, it exacerbated these problems that were there already. And that also was intertwined with race. This looks at Hispanic Americans, Latinos, Latinas that had the steepest initial employment losses and still had the most ground to make it up post-pandemic to get to pre-pandemic levels. While white Americans recovered more than half their jobs lost between April and January, Black Americans have only recovered about 1/3 of their jobs. And again, this is tied in to race, education, and income. This looks at unemployment rate by degree type. You have Black, Latino, white, and you go from advanced degree to less than high school diploma. And for every racial group, right, less education, there is more unemployment. But Black, less than high school diploma, much more unemployment than white, less than high school diploma. So these are the same patterns we had pre-COVID, now becoming exacerbated post-COVID. And perhaps what's saddest about this is that it didn't have to be this way. This looks at the three previous recessions, 1990 recession, 2001, 2008. And what it does is the green line is the highest earning 25%. The purple line is the lowest earning 25%. And what you see here is that in previous recessions, while there was a little bit of divergence between how in employment, how the richest 25%, the poorest 25% did, there was nothing like the COVID crisis. The coronavirus crisis resulted in this enormous widening of the highest earning 25%, the richest quartile versus the poorest quartile, in that essentially the economic consequences of COVID were borne exclusively by the groups that already were the have-nots, widening the gap between the haves and have-nots. It is then no wonder that we saw the anger that emerged in the middle of 2020 around racial issues. Now, a lot of this, of course, was triggered by the murder of unarmed Black men and women, and particularly starting with George Floyd. But the civil protests that emerged from this, which, by the way, the 2020 civil protests were the largest civil protests the country's ever had numerically, in terms of the number of people who participated in them. They weren't just about that, right? They were reflecting these deep-set underlying divisions, these deep-set underlying divides in terms of haves and have-nots that we have long ignored, even though we've long known they were there, and COVID simply revealed them. So we talked about health haves and have-nots. We talked about health haves and health have-nots, and we talked about how COVID has widened those gaps. Well, it is then no wonder, of course, that COVID also resulted in divides around COVID. Well, the most obvious of these probably is COVID divides by race, and I could talk about different racial ethnic groups, different groups, people of color, but just to talk about Black Americans disproportionately have been affected by COVID, with about 25% more deaths than is that would be relevant in terms of population adjusted rates. Black Americans have died at about 1.5 times the rate of white Americans. Now, it's important when we look at data like this to understand what's driving it. What is driving it? Well, what's driving this is there are different forces at different stages. And I want to illustrate this by looking at this. This looks at 5 jurisdictions: DC, Illinois, Michigan, Tennessee, Wisconsin. They all behave the same way, but just focus on the left, just focus on DC just for ease. What you have here in the bars, the blue bar is percent of the population, the orange bar is percent of COVID cases, and the gray bar is percent of COVID deaths. So starting from Black, you see the blue bar, which is percent of population in DC. You see there are more cases than there is population, and then there are more deaths than there are cases. White is the opposite. There's more population than there are cases, more cases than there are deaths. So the import of this is as follows, is that when we say there was a differential death rate for a particular racial group, let's say Black versus white, we need to tease that apart and realize there are 2 factors that contribute to that. Number one is a higher rate of getting COVID, and the other one is a higher rate of dying from COVID if you get COVID. And the risks for both those are different, and it's important to think of them that way. So let's move to then health haves and health have-nots in a time of COVID. Why is it that there was this disproportionate mortality by race in time of COVID? What were the forces that created this differential risk of getting COVID and this differential risk of having severe COVID if you get COVID? Well, first of all, is it about our treatment of COVID? And the answer is it's not about our treatment of COVID. This is from a paper that comes out of the NYU group that looks at differential mortality for different groups who are in hospital. Essentially, the bottom line with this graph is there was no difference. So what is it that drove difference in getting COVID and difference in having severe COVID once you get COVID? Well, first of all, what drove getting COVID? Well, what drives getting COVID is contact with others, right? It's actually that simple at some level. And particularly when COVID first hit, when we didn't understand what was going on, what we did understand is that the way to protect ourselves was to isolate. Well, who could isolate? Who did isolate? So this is from a paper that I was involved in, which looks at people with smartphones, everybody with smartphones, staying home all day. And this looks at income quintile. The purple is the richest 20%, and then you move down to sort of to the poorest 20%. Look at the purple line. You see that the richest quintile were less likely to stay home until COVID hit, beginning of March. All of a sudden, that group jumps to being the group that's more likely to stay home all day. Conversely, of the right, you have proportion of smartphone users who work outside the home. Again, the richest 25%, that 20% were more likely to work outside the home, and then they dropped and became much more likely to stay inside the home. Of course, having less income is associated directly with your ability to work remotely or not, as the case may be. There's a clear dose-response relationship. This is from Bureau of Labor Statistics data. The more income you have, the more likely you are to be able to work remotely. So of course, when you have less income, you are going to be more likely to not be able to work remotely, and as a result, to be more exposed to COVID. And of course, that has implications as well for race. This is likely employed in essential industry, which means you can't work from home, which is where you see Black Americans are more likely to be employed in essential industry than anybody else. So reason one why there were differential deaths from COVID is because there was a greater risk of getting COVID because of the underlying socioeconomic structures that create opportunity for some people to work remotely, not work remotely, to isolate or not isolate. That's reason one. But now, once you get COVID, what about risk of getting severe COVID? Because of course, just because you get COVID, it doesn't mean that there should be differences by racial groups. Well, insofar as there are differences then of risk of severe COVID, it's because of the underlying conditions that make COVID more deadly. Well, what are those underlying conditions and how do they distribute? This looks at household income by deciles on the x-axis, and the yellow bar looks at people who have illness that makes them vulnerable to COVID. You see, the more income you have, the less likely you are to have illness that makes you vulnerable to COVID. The green bar is underlying mental health condition, which then makes you vulnerable to mental health problems because of isolation. The wealthier you are, the less likely you are to have those underlying mental health conditions. And if there's one thing that we've known since the beginning of COVID is, and this data from China, from the early wave of COVID from Wuhan, is that it is underlying conditions like cardiovascular disease, diabetes, chronic respiratory disease that put you at risk for severe COVID. So we've known this from the beginning, that it is actually quite rare to have people who die from severe COVID if they don't have underlying conditions. But those underlying conditions are not evenly distributed. I've already shown you this in terms of the health haves, health have-nots. We hit a country where there was immense socioeconomic and racial patterning of underlying conditions. So then it's no surprise that when COVID hits, which disadvantages those with underlying conditions, it is going to create a disadvantage on those who already have health disadvantage. That's why we see patterns like this. That's why we see these race gaps, and they're particularly accentuated among young people. This is white is blue and black is red, and there's Latinos is gray, but just focus on white and black just for ease. You see how much wider the race gap is in COVID deaths in younger people than it is in older people? Was because by the time you get to older people, all races now have underlying conditions. But in young people, it is more people of color who have the burden of being health have-nots mapping onto them being resource have-nots to begin with. Now, I've just talked about COVID, but I do want to point out that is also the case for the other morbidities that's accompanying COVID times, including, for example, depression. We know from work that our group did and other groups that depression has tripled in a time of COVID from what it was before COVID. But the tripling is not evenly distributed, not at all. This actually looks at the groups and predicted probability of depression in various groups. There are 4 groups we looked at, but just look at the extremes just for a second. On the right, you have people with low assets and high stressors. That means people who had no savings, who had low income, who are worried about paying the rent because of COVID. On the left, you have those with wealth, with savings, who weren't worried about paying the rent, weren't worried about sending their children to school. There is a 4-fold difference in risk for depression between people with the high assets versus people with low assets. So yes, depression was a big problem in time of COVID, but it wasn't a problem evenly experienced. It was a problem that is experienced by those who are health have-nots to begin with. Now, as I start to conclude, let me just take a long view for a second, and then I'll wrap up. Because we're talking about COVID, and hopefully I've made the case abundantly clear that much of what I'm saying, I could have said 5 years, 10 years before COVID. Because the picture that set us up for COVID is a picture that's been there for a long time. And COVID itself is just one piece of a much larger puzzle of health haves and health have-nots in this country. First of all, there's a whole array of other disorders. I've talked a little bit about mental health because I think it's really important, that have been problematic in the past year. This looks at per month in 2020, and these are other diseases: strokes, Alzheimer's, diabetes, hypertension. The bars represent the deaths we had during 2020. The blue line was the previous 5 years average. And what you see here is that deaths from stroke, Alzheimer's, diabetes, hypertension, they were all higher than they were in the COVID time than they were pre-COVID. And that, of course, reflects both the burden of comorbidity and the fact that we actually weren't paying attention to risk behaviors and all the other conditions that contribute to these deaths. The other point is that the socioeconomic and racial divides that I showed you in health go back centuries, right? So this is from a paper that came out recently. On the left, you have mortality rate. On the right, you have life expectancy. Black is the light blue and white is the darker. So first of all, you see mortality has gone down for everybody over the past century. This is a century worth of data. But you see that black mortality has been higher than white mortality every point. That maps onto life expectancy on the right, that white life expectancy is higher than black life expectancy. I already showed you that. By the way, note for interest, a dip in life expectancy, you see that was in 1918, which was the last other great pandemic, right, 100 years ago. But the import of this is that over time, when you look at that mortality and life expectancy comparison, you're dealing with hundreds and hundreds and thousands and millions of deaths disproportionately borne by Black, Latino, people of color over time. That has nothing to do with COVID. This is underlying baseline that reflects our status of health haves and health have-nots. So we appropriately are focusing on the differential mortality of people of color in the context of COVID that accounts for tens of thousands of deaths. But we have to keep in mind that that is on top of hundreds of thousands of deaths that are already differential mortality due to differential burden of resources before COVID. The other point in terms of taking the long view is we got lucky in COVID. Now, I know it doesn't feel like we got lucky at all. I know that's a strange thing to say, but COVID could have been much worse. This is mortality rate from other major virus outbreaks. COVID is SARS-CoV, which is the second from the right. Probably mortality from COVID is going to end up being about 2%. But SARS mortality is about 9%. MERS was 34%. Ebola was 40%. And, you know, we tend to think Ebola is something that just happens over there. Well, there's no reason why. In fact, for years before COVID, I would use Ebola as an example to say, well, why can't this happen here? And COVID has shown us that it can happen here. And these diseases have much higher mortality than what COVID has had. And importantly, while COVID has been devastating in terms of deaths, this is a slide that was made that when we had just under 500,000 deaths from COVID, which is the bar in the middle. Well, at the same time period, there were about 3.7 million other deaths from other causes. And those other deaths were characterized by the same socioeconomic and racial divides that I'm showing you here. So the picture is that COVID has galvanized our attention on something very particular, but that particular thing that galvanizes our attention on is something that has been there all along and continues to be there for all sorts of other diseases. And as our response to COVID has evolved, we have been coloring that by creating conditions that are just deepening those divides, unfortunately. Perhaps most remarkably, in our school approach to schools and keeping schools closed. This is looks at the RASH score for math for grades 3 to 4, 4 to 5, all the way to 7 to 8. The pink is last year, the green is this year. Notice how the curves are all shifted to the left, which means all kids are doing a little bit worse than they were. But that's not evenly distributed again. Look at this. This is math learning again from math K to 5 all the way to 5th grade of math. And there are these bars that look at where students are at. The dark dot is where schools with more than 50% students of color. The light dot are schools with more than 50% white students. See how there is this separation of the two groups? So those who are already in the have-not category are becoming more have-not, as now they've been denied education, which is why the whole school argument that we've been having nationally is in some respects so sad, because it is disadvantaging those who are already disadvantaged. And if there's one thing we know, it's that education is one of the most important protective forces in our society. This looks at Latino, Black, and white. And all I want you to see here is the these are different color bars that go from having less than 8 years of education to having more than 16 years of education. All three racial groups behave the same way. But fundamentally, the more education you have, the less likely you are to have mortality. And that means something very simple. It simply means that as we are creating less education and creating more differences in education, we are going to be creating differences in mortality in the long term. So let me conclude. And I want to conclude by talking about the contagion next time. I'm using this phrase to talk about the next pandemic, and of course I'm using it as a tribute to James Baldwin's book, The Fire Next Time. James Baldwin's book, The Fire Next Time, is a searing indictment of racism in America. And the reason I'm using the title is to simply make the point that unless we deal with these more fundamental forces, racism being one of them, we will not have a better result at the next pandemic. It doesn't matter how good we are in our biomedicine, because we can keep treating the malaria, we keep investing money in malaria, and we'll do well with treating malaria, but we will still have the same social patterning that we're seeing here because of all the other forces that I talked about. This is from the cover of Time magazine a couple of years ago, which said we're not ready for the next pandemic, and they were, of course, right. But of course, when you look at the mainstream conversation, getting ready for the next pandemic means thinking about better biosurveillance and detection systems and vaccine development, all of which is important. I do not want to be misconstrued as saying this is not important, but fundamentally, that's all just part of a larger picture of the underlying structures that create a world that makes us vulnerable to things like COVID. So I'll conclude, and I'll conclude with my last slide, and I'll conclude with a sports metaphor, because I think it's good to end on things that give us joy. And I'll conclude with a picture of the best soccer team in this country, which is the US Women's National Soccer Team. And I concluded with this metaphor because I want to explain how soccer works for those of you who don't play soccer. Soccer is a very simple game. You have 11 people on one side, 11 on the other, and you just have to get the ball into a net on the other side. That's all you have to do. If nobody scores against you, you'll always win. So if I say to you, I'm going to give you $1 billion and build a soccer team that never loses, you might say, oh, I'm just going to invest that $1 billion in the goalie, because nobody will then score against me, right? If I have the world's best goalie, she can save every goal. But if you watch professional soccer and you watch how it's played, you'll see that during a game, the goalie, that's the woman in black, her name's Alyssa Nair, is in front of her net and she's constantly prowling, looking anxious. And she's constantly yelling at her fellow players. And what she's yelling at them is, keep the ball away from me. Now, that's not because she's not a good goalie, because she's a very good goalie. But it's because a good goalie knows that the net is big. It doesn't matter how good she is. A ball comes at her fast enough, it's going to go in. To win at soccer, you can't just invest in the goalie. You have to invest in the other 10 players. You have to invest in players that actually move the ball forward and try to score in the other net. Now, why am I telling you this? I'm telling you this because, of course, the goalie is medicine. The goalie is our clinical care. But in order for us to actually create health, we need to invest in the other 10 players. We need to invest in housing and stable income and gender equity. Make sure there's no domestic violence. Make sure there's no violence in general. All of those forces are the forces that we need to invest in. And unless we do that, we're never really going to win at soccer. And we're never really going to do better when we have the contagion next time. I will stop there. Thank you for having me. It's a real privilege to be with you today. Thank you.
Dr. Galea, that was incredible. Thank you so much.
Thank you, Dr.
I think we have some questions from the audience, so I'm going to get to those next. Here's a great one. One of Blind Willie Johnson's most famous known songs is "Nobody's Fault But Mine." He wasn't singing about his health issues, but that line is applicable. Individual behaviors are a factor in health and wellness, but so many social determinants are beyond the individual's control. To help the health have-nots, how do we separate what people can and cannot control when making new public policies?
What an excellent question.
Yes, it is.
And it gets extra points for being grounded in Blind Willie Johnson's work. Thank you to whoever asked it. I think it is a terrific question because it gets at the heart of the confusion that we often have in society, where we are confused and we say, well, if you have less income and let's say you use more alcohol, then you have bad things happen because of alcohol. It's because of your bad behavior. But the truth of the matter is that we know amply well from the science that our behavior is constrained by the choice set presented to us given our circumstance. Let's take perhaps the best example of this in the 20th century. What is one of the biggest triumphs of public health in the 20th century United States? Well, that is the reduction in deaths from motor vehicles. So we dropped motor vehicle deaths by about 200-fold per vehicle mile driven over the 20th century. Now, how did we do that? Is that because we made people better drivers? Well, I live in Boston, and you can come visit, and you can rest assured it's not the case. No, you all know how we did that. It's through seatbelts and airbags and making sure people don't drive while they're under influence of alcohol, and through shatterproof glass and things like that. That's how we did it, right? So what we did is we changed our choice set and we created health. It is similarly the case that the more resources we have, the more health-producing choices we have available. If you are fortunate enough to live in circumstances where you live, where you work, where you play, it's safe, where the air you breathe, the water you drink, the food you eat is nutritious, you are going to choose. You are going to make, quote unquote, better choices. But you are choosing from a choice set that is ultimately constrained by your resources. So the answer is, blind Willie Johnson himself may have felt he was making choices, but remember, he's making choices based on the choice set in front of him. And we all do that all the time. So our job in health is to create as many healthy choice sets for all of us, irrespective of our resources, of our income, of our wealth.
But let me challenge that or probe that just a little bit deeper, because I don't think you can go out and purchase a car now that doesn't have seatbelts. Okay?
Okay.
I mean, when I was a little girl growing up, we didn't have seatbelts in cars. Now, when you go out and purchase a car, many of them have airbags. Whether you ask for these safety features or not, you're going to get them. You're going to have the lights automatically turn on. So there are features to drive down motor vehicle deaths that we have taken out of the choice of an individual and just said, we've just decided, meaning society, meaning Detroit, right, that we're going to pre-program these safety features into the car, correct? So we've taken some of this out of the individual choice to just make a global decision that we know drives safety and will save
Absolutely.
lives.
And what you're getting at, Dr. O'Connor, is that we make societal decisions about what we want to allow in our choice set. So we allow burgers. We understand at some level that it's not the healthiest food, right? We could choose as a society to make burgers illegal. I'm choosing it as an example, as a silly example on purpose, right? And we don't choose that. Now, we don't choose as a society because we are waiting that the pleasure that comes from eating a burger collectively outweighs the negative effects of the burger on cholesterol and all that. The point I'm making is that these are value decisions that we make as a society. And it's a value decision that we made that we're willing to have to put on a seatbelt in order to protect our safety. Now, what is now taken for granted, seatbelts and airbags, wasn't so straightforward. There were decades of argument about getting us there. So the point is that these are values that we as a society have to adopt. And we as a society have to adopt a value where we create healthy choice options for everybody, regardless of their socioeconomic position. And that's a value that we have not yet committed to. And my hope is that in the context of COVID, with the clarity of day that COVID brings, that we will make that commitment.
Well, I hope so too. And it's certainly something that we all need to work towards. Let's get to some other questions. Here's another good one. It'd be interesting to know what happened to income overall and income inequality during the last administration, 2016 to 2020. Can you comment on this period specifically?
Yeah, a lot of these data always lag because there's a whole bunch of that happen afterwards. But certainly the numbers that I've seen are that there wasn't any particular inflection in this past 4 years in the previous administration, but rather it continued the trends that have been there for the past 30, 40 years. Certainly there was no correction in the growing inequality, but I'm not sure that there are data yet that show there was a particular inflection one way or another.
And you presented a lot of very compelling data regarding income inequality between whites and blacks. What about Latinos?
Yeah.
Where do they fit in this in the scale?
Yeah, Latinos fit in quite comparably, typically, to Black Americans. And in fact, on some of my slides, I had Latinos, so I was just focusing on the white-black person just for ease. Typically, they're sort of somewhere in between. The Latino picture is more complicated than the Black American picture in terms of health, simply because there is enormous heterogeneity in what we call as Latino. So when we collect data, ethnicity data that is sort of Hispanic, non-Hispanic, or Latino, non-Latino, it is a far broader swath of Americans with a lot of different inputs and differences in terms of migration status that makes the health picture more complicated. But broadly speaking, socioeconomically, typically you find Latinos somewhere between Black Americans, white Americans.
Thank you. One of the slides that you showed that I found probably the most disturbing of many that were all disturbing was the slide where you showed that younger people, African Americans and Latinos who are younger, are at such a higher risk of comorbidities compared to younger white individuals. And of course, I know this from our Movement is Life work and the Disparities work that we've been so involved in, but yet to just see that on the slide, it really, took my breath away, because I thought, oh my God, like are we doomed? Is there no path forward that can be more positive when this next generation is growing up so sick? I mean, we're just going to have, it's almost like this vicious cycle where the sick get sicker, and they get sicker now at a younger age. And is there no ability for us to break this cycle?
Yeah, no, I refuse to concede that we're doomed, because yes,
good. I don't want us to be doomed. I was just trying to convey the emotion.
I think we are doomed if we don't pay attention. But I am trying to fill myself with hope and to say the moment has taught us. The moment has taught us that this is an issue. This has long been an issue. It has surfaced issues that have been an issue for decades. And I'm hopeful that what will emerge from the moment is a doubling down and a commitment to values that will fix this. I mean, we can do this. I mean, we can do this. We are effectively choosing to create health haves and health have-nots. And I think we can choose to not create it. We go back to the car metaphor that we're using, Dr. O'Connor, which is we choose to create a world where seatbelts are default. We can choose to create a world where equity in health is default.
Yes, we want to choose a world where health and equity is the default. But we know that there are a lot of structural forces and systemic forces that come into play. And so one of the comments from one of our viewers, racism is why the social determinants are the way that they are. That won't change regardless of the new COVID insights and clarity. So your comment on that.
I mean, it won't change if we don't act for it to change. But I would push and say it could change. And I think the broad societal conversation about the pervasiveness of racism and the anti-racist movement is a really important turning point. And I think it can be an important turning point. And I think there is responsibility on everybody's hands to make sure that that moment does not get lost. Now, I do worry that sometimes some of these, our engagement with these forces is sort of a performative, and we're not thinking deeply about what implications it has for how we structure our health systems. But I think if we think carefully, it can have real implications, and we can actually transform, how society is structured, learning on the moment.
So I want to talk for a moment about Ebola and the next pandemic. And my question is, why has Ebola not really happened here? How did we avoid Ebola, an Ebola pandemic here, where we have failed to avoid a COVID-19 pandemic here?
Yeah, so a couple of answers to that. Number one is luck, and we should not forget that. I mean, we can talk about Ebola, but let's talk about SARS, for example. SARS went from Southeast Asia and was an enormous problem in Canada. I mean, why did SARS go from, I was in New York when SARS hit. Why did SARS not go from Toronto to New York? I mean, fundamentally luck. It was fundamentally luck. It was idiosyncrasy. The other element, and to get a little bit more epidemiological about it, there are disease characteristics, which are features of transmission, how transmissible something is, as well as features of how fatal something is. So paradoxically, diseases that have higher fatality transmit less because, of course, they kill the host, so the hosts are less likely to transmit. So it's all these forces, but fundamentally, it's luck that we haven't had a pandemic like this for really 100 years that has traversed the globe as much as COVID has. And there's no reason to believe, it's a human cognitive error to say, well, we're done with that. That means we're not going to have a pandemic in 2022. There's no reason to believe that. I mean, there are novel viruses crossing over into the human species all the time. I mean, we could be ending COVID and to start something else next year.
Yes, I do think that that remains our future, right? This will probably not be the last pandemic that we encounter. Hopefully we won't have one maybe ever again, but that's probably not realistic. So I do hope that we're really looking as a society to help address our systemic and structural issues and support individuals to be able to be healthier, right? Because we have to address the pandemic of these chronic conditions. All right, let me get to some more questions and comments because we have quite a few. What thoughts do you have about how large corporate entities can leverage their resources to address these issues?
Yeah, it's an excellent question. I think we over-rely on the notion that the public sector needs to solve everything and save everything. And most of us actually work for private entities, not public entities. And I think the private sector shapes, I've talked a lot about the conditions where we live, where we work, where we play. Well, where we work is mostly shaped by private sector influences. So I think large corporate entities and small corporate entities have a responsibility. I work for a private institution, I work for a private university. And I think these institutions, these organizations are deeply important in terms of shaping the lives of the people who intersect with them. So I do think that we as a society should choose to reward private entities that see that, private entities that behave in a way that is in accord with promoting health. And by reward, I mean both in terms of working for, but also patronizing and giving our resources to those corporations. And I do think this goes back to my optimism. I am really trying to stick to optimism that we are seeing a growing awareness in many private sector actors that they can play a role in creating this better and healthier world.
Yes, I agree, and I certainly hope that trend continues. And I also agree that kind of a general elevation of social awareness and where I, as a consumer, am going to spend my money or support one entity over another. I think that matters, and that can reward groups that are trying to improve the world, and not those that are just out there to make a buck. So
I agree.
Hopefully that will continue. Okay, here's some comments. Excellent presentation, thank you. Love the soccer analogy. What can we do as healthcare professionals to reduce these disparities and create a society that has health equity?
Yeah, I think it's an excellent question. I've written a bit about this, and I think that healthcare professionals should never underestimate our narrative, predominance in the health space. People look to healthcare professionals to tell the story of health. That means you can all tell the story of health, just like I can tell the story of health. And if everybody on this call tells the story of health to 10 other people, just think how many more people will actually hear the story. So take the analogy, it's yours. Please go out and tell it to everybody. So I do think we will not change how we act until around the kitchen table, when a relative is asked, so what matters most for your health? She says, politics. Right now, if you were to ask somebody what matters for your health, she's going to say the doctor. Well, it's not really the doctor. What really matters most for her health is politics, her house, her income, her wealth. That's what really matters for health. And we need people to understand that, because those in positions of authority to make decisions, decision makers follow where the public conversation is. I think our biggest responsibility is to change the public conversation.
Excellent. A holistic philosophy of health is needed. This is from one of our viewers. And this concept of health should start in elementary school and promote public health, especially in urban areas. What are your thoughts?
I couldn't agree more. It is on my long to-do list to write a book about these ideas for high school or elementary school, to make these ideas translatable. Because right now, I agree completely. It is our kids do not understand this, right? And kids finish high school, and there are certain things they understand. And if we had everybody who finished high school who understood this message, it's a simple message, right? Just think how much easier it will be then to have policy or to have private sector aligning with these messages. So I do think that there is a real pressing importance to make sure that this message gets down through the pipeline, through high school and elementary school. And right now it's not there at all.
I think that is an incredible comment from Eleanor about, reaching down to younger children at the educational level. But I also think that, we have opportunity to reach out and engage the parents or the adults in families, because if they change their health behavior, that will influence the behavior of their children. And, one of my stories that I love is from our Operation Change program, which is our program that we have for women with knee pain and obesity. And it's an 18-week community-based program. And so Maria was one of our Operation Change participants in Chicago, and she started to cook some healthier food, a healthier dish for herself at dinner. And her husband was like, I don't want that. I'm not going to eat that, right? But she kept consistently making the regular stuff that he was used to and the children were used to, and then something healthier for her that she would also eat. Then the children started eating what she was cooking that was healthier. And then just took a little while, the husband starts eating it too. And so I've always seen that as so powerful, because she is like the pebble in the pond, right? That ripple of a wave out, really influencing all the people in her family to promote health, as opposed to just her. And certainly the younger that we need to influence, we need those pebbles in the pond to be with multiple people, right? That could be a child in elementary school. It could be a child in high school. It still could be the mom. It could be the dad. But to approach it from multiple perspectives to try and impact the health of that family. Because as you know better than I do, obesity is in families. I mean, the way people eat is the way everyone in the family eats. How active they are is how active people in the family are. So it's really creating that mindset of healthier behaviors within families and then within communities.
I agree completely.
Okay, let me get to some more, because we've got some other great comments. This is a comment from John. The Office of the National Coordinator for IT Chief indicates a focus on making public health data systems health equity by design, a step in the right direction to a world where equity is a default. So I'd just like you to comment on that.
Yeah, I think it's a wonderful, wonderful illustration of the seatbelt analogy. It is to create equity as the default option, to create as the default option that we act in a way that we make sure that there are no left behinds by any dimension. I mean, we talk often about racial dimensions, obviously by socioeconomic dimensions and other dimensions. I actually think that that is the only way we are going to move towards erasing a health have and health have not gap. So I wasn't aware of the example. It's a great illustration, though.
Here's another question from Leslie. Medical education remains focused on the 10 to 20% of impact on health, biomedicine. How can we change that focus? Yeah, she's asking how we can change the focus. I'm also going to ask a follow-up question. I mean, should we change the focus?
It's a great question. Sorry, I'm going to cut you off. So I'm not sure we should change the focus. I think, remember, we still need goalies. So my argument is not an anti-goalie argument. So it's we still need goalies. But we do need the goalies to know that they're part of a team, right? So the example I have to use is like, when I have a heart attack, I'd like the best possible doctor look after my heart attack. So, when the ball's coming at the net, you don't want the striker to be stopping the ball from getting the net. You actually want the goalie to catch the ball from going the net. So medical school is teaching people how to be goalies. We want them to be good goalies, but we also want them to know how they can play as part of the team. So I'm not sure that we need to change all of medical education. I just want to make sure that medical education understands that it's part of a larger team of players, so to speak, that generate health. And I think if doctors did that, if doctors understood that and they made that part of their narrative, it would be transformed.
So I do think that medicine and healthcare professionals in general are starting to appreciate to a much greater degree the social determinants of health and the impact. That doesn't mean that they feel empowered to be able to affect change, right? I can't individually help that patient live in a different neighborhood, breathe healthier air, right? And so I think it gets very frustrating. I'm just speaking for myself as an orthopedic surgeon. It gets very frustrating to see those patients and know that their health is being negatively impacted, but not feeling like that I personally can do something. So how do we collectively make the rest of the players on the team better and stronger when, using your soccer analogy, right, we are red carding, right, some of those players, like safety net hospitals, like rural hospitals that we're closing, like access to primary care, food deserts, food swamps, all of these structural issues that impact a person's ability to make better choices. How do we get the resources allocated to improving those conditions, which of course is the real question.
Yeah, there's no magic answer to this other than to say that doctors need to be part of the solution, and being part of the solution means committing to this story, committing to this narrative, and making that cases. I mean, you mentioned Dr. O'Connor, safety net hospitals. That's a perfect example. I think moving beyond the doctor, the goalie, saying, well, it's all about malaria, it's all about what I do, to saying, yeah, that's important, but what I do, we're still going to lose if you leave it all up to me. Because, and being a voice to saying these other factors matter will ultimately change the conversation. And just to be clear, doing that is a dramatic change than what doctors have done for many years. I mean, the doctors have, for many decades, essentially said, we are health, we are what matters. So, Dr. O'Connor, I agree with you saying that there's more doctors now and more medical associations seeing the importance of social determinants. That is a shift, that is a dramatic shift. And now's the time to lean into that and to make sure that doctors offer their voice as part of this broader narrative.
And I agree completely. And I think that shift is occurring, and I hope it continues to occur and that the voices grow even stronger. How do we also impact our policymakers? I mean, it's the people in power that end up making the decisions about where resources are going to be allocated, right? Where is that park going to be built? Is that new park going to be put in an affluent section of town, or is it going to be put in a less affluent section of town?
That is exactly the kind of discussion that we should be a part of. That is exactly, look, there is a price to health equity, and we should be careful that we think deeply about these things and that we think beyond the simple sort of performative commitment to these ideas. Health equity means there is a price to that. I think Dr. O'Connor used an example. Should the park be put here or should it be put there? If there's only going to be one park, then you say it's going to be put there. Well, it means it's not going to be put here. And are we willing to countenance that? And the truth is, those who are the haves have not historically been genuinely willing to say the park should go over there. We have not been willing. We say so, and we use it on our bumper stickers, but we have not been willing to do that. So I do think this is a price to health equity, and it's one that we should be willing to really sort of put our money where our mouth is, so to speak.
All right. I think this leads perfectly into this question/comment about the haves and whether the haves have actually been willing to affect change to benefit others. You shared life expectancy data for the United States compared to other countries, and it did not look good by comparison. But that is the average value. For high-income men born around 1960, they can expect to live at least a decade longer than low-income men born in the same year, and that gap is growing. In fact, life expectancy for high-income men in the top 40% of income is now nearly 90 years. We don't seem to see that amount of variance in the comparator countries, meaning you showed Australia, France, right, those countries where you compared them to life expectancy here. Is a big part of have and have-nots that people with more decision-making power are actually doing very well out of this health system, so they are resistant to change?
My answer is to an excellent question is yes. I do think that is exactly the case. I actually do think that the dirty secret is that we're not willing to really say this, is that we, and I'll use the term we, the richest 20%, those of us in healthcare are really in the richest 20%, have not been willing to actually truly support the policy and decisions made that will create wealth and create opportunities and create health for the poorest 80%. The pandemic is one of the best examples of this. Look, the pandemic has been hard on all of us. It's been tough on all of us. But I wrote a piece which was called How to Get Wealthier and Healthier During a Pandemic, because the data are very clear that those with more than a college degree actually got wealthier and healthier during the pandemic, not less so. We never talk about that. That's a bit of an uncomfortable truth. That's an uncomfortable truth because the pandemic really affected people with low wages, with less wealth to begin with. Are we willing to be honest about that? And I think we should be honest about that. And I think we should be willing to say that we are willing to pay more taxes. We are willing to make sure that resources are directed at those who need them most. And that's a tough call. And history is, if there were one thing I would be skeptical about us being able to get to, is this, because history does not show that those who are in the richest 20%, to keep using the terminology, are that much willing to give up the things that they have already gathered onto themselves. And I think in some part, we have to do that. We have to be willing to do that.
Doesn't this fundamentally get back to the concept of a strong middle class? I mean, even not looking at the very low income segment of this population, which still, of course, needs support. So I'm not trying to marginalize those individuals. But I'm trying to say, if we see this growing wealth gap and inequity, we're losing the middle class, right? Yes. And isn't the middle class just critical to us in terms of public health? So from putting your public health hat on, how important is a strong middle class to helping to prevent the next pandemic or controlling a pandemic when it occurs?
Well, first of all, what exactly is the middle class is highly debatable, but leaving that aside, look, life expectancy for women in the past 40 years has risen only for the richest 20% of women. For the poorest 80%, it has either stayed the same or has gone down. That is, to me, extraordinary. Now, the middle class, let's take the middle 60%, because I talked about the richest 20%, right? And you have the poorest 20%, let's take the middle 60%. The middle 60% has not budged. That's not right. It shouldn't be that way. We should be building a society where health improves for everybody, and particularly if we care about population, that word population, we should care about the middle 60%. The middle 60% is the majority of the world. And we should be creating the economic and social opportunity structure to create health for that group. And we're simply not doing it.
So you talked about our focus on biomedical solutions and how we continue to think about biomedical solutions as saving us, and how we're looking at biomedical solutions to save us in this pandemic, right? It's the vaccines. The vaccines are going to help people not get so sick that they die from the virus. They're going to give people more confidence that they can go back to resuming something that looks like a more normal life. How do we help people switch their mindset from it's not just biomedical science that is going to save us, but investing in public health, investing in these things that we know will improve social determinants of health?
I think it's through having this conversation again and again and again. And I don't say that glibly. I actually do think that what we do and how we structure our society reflects our conversation that we have collectively, the truths as we understand them. And I don't think that this truth that we're discussing is well understood. And now, sometimes one of the challenges is I think we find ourselves in rooms like this, digital in this case, where we often are talking amongst ourselves and people who understand this, but we forget that outside this room, there is a lot in this conversation that's pretty radical. And how does that change? Well, things that were radical eventually become commonplace and then become common sense. It takes time, but it takes insisting on moving the conversation forward, shifting the Overton window. There's this concept of the Overton window, it was named after William Overton, which is there's a window, and within this window are the things that we find acceptable to discuss. The trick is to shift the window to make sure you allow other things to get into the window. This conversation is shifting the Overton window. And in my book that you referred to, Dr. O'Connor, I actually talk about this. I talk about the Overton window because I think it's a really important concept of saying, how do we shift what we find acceptable to discuss?
Well, I think that we have encouraged the shifting of what we find acceptable to discuss with this symposium today. And so I just want to thank you because you've been, as I knew you would be, a fabulous presenter and great comments and answers to the questions. I want to remind all our attendees, listeners, and watchers that a replay will be available in a couple weeks on our Movement is Life website. So you can see this again. You can share it with your friends for those people that couldn't join us today because sometimes schedules are tight. And Dr. Galea, I just want to give you the opportunity to close with some words of wisdom or your closing thoughts for the group.
One of our staff in the school today used the phrase that she is leaning on rainbows of hope, and I thought it was a beautiful expression. And it's hard to have hope when you're going through a pandemic year and year plus. And what gives me hope is thinking that we have learned from this moment. And if we have learned from this moment, if we can have this conversation and consider this conversation as nudging the conversation forward. And if we're having this conversation because the pandemic happened, that is hope. That is a good thing. And now we simply need to make sure that we continue having this conversation and we shift the national and global conversation along.
Absolutely. So I want to thank everyone for joining us today. Ask everyone to be safe, stay well, get vaccinated when you can, and thank you for advancing health equity. Everyone have a great day.